Welcome to the deep dive. Today we're plunging into a really fascinating and maybe often misunderstood symptom, hallucinations.
Mhm.
But we're going beyond, just hearing voices or seeing things. We're focusing specifically on the sense of touch, what are known as tactile or haptic
Right,
hallucinations.
exactly. Because when people think hallucination, their minds usually jump straight to auditory or visual.
Yeah.
But feeling things that aren't there, like you said, being touched or pushed or just feeling physical sensations when nobody's around, that feels like a much less discussed area.
Absolutely. So the question is, how common are these phantom touches? And well, what does it even mean when someone experiences them?
Yeah, what's going on there?
We're going to try and unpack all of that today by diving into this stack of sources you've shared, which includes some really compelling case reports and an insightful descriptive study.
Yep. And our mission really is to extract the most important nuggets of knowledge, the key insights. We want to understand how these tactile hallucinations actually, show up. What conditions might they be linked to? And yeah, some of those links are quite surprising, I think.
hmm
We'll explore what brain areas could be involved and even look at a potential non-drug way, a non-pharmacological approach they might be managed.
Okay, let's jump right in then, see what this material reveals about these really unusual sensory experiences.
So, okay, basics first. The sources define tactile or haptic hallucinations pretty simply. They are sensations of being touched or a false perception of touch.
Right, just feeling something real in your body, but there's no actual external stimulus causing it.
Exactly.
Okay, so let's unpack this a bit. Historically, these kinds of phantom sensations, they were often seen as signals of, well, a physical or neurological issue, weren't they?
Yeah, that was definitely the thinking for a long time.
The sources mentioned them being associated with things like drug use or withdrawal, Parkinson's disease,
hmm
or sort of sudden brain changes.
hmm
The idea seemed to be, that they often point to an organic issue, something physically wrong with the brain or the body itself.
That's the traditional view. And the sources actually offer a really powerful example of how a physical event in the brain can indeed trigger these experiences. One of the case reports you shared specifically links tactile hallucinations to a stroke.
Okay, stroke. I mean, it's a major cause of death.
Mhm.
And while psychiatric issues like depression are, unfortunately, quite common afterwards, psychosis, which includes hallucinations and delusions, that's considered relatively rare post-stroke, right?
That's generally true, yes.
Yeah.
It's considered rare. But when psychosis does happen after a stroke, it's often very strongly tied to damage in specific brain regions.
Oh, okay.
And what's really interesting here is that the sources highlight these key areas, places with a higher likelihood of being involved in this post-stroke psychosis, particularly the temporoparieto-occipital sections.
That's a mouthful.
It is. Think of it as areas deep in the brain, kind of at the junction of the temporal, parietal, and occipital lobes. They're heavily involved in processing sensory info, spatial awareness, our sense of our own body, that kind of thing. And damage there, especially, it seems, in the right hemisphere, seems particularly implicated. Though deep subcortical structures can also play a role.
Okay, so this is where that specific case report comes in, I imagine.
Exactly. It describes a 61-year-old man who had an acute ischemic stroke. That's the kind caused by a blood clot blocking blood flow
hmm
in the right middle cerebral artery border region. And this area included precisely that temporoparieto-occipital region we were just talking about.
And what happened to him?
Well, the result was he developed these vivid tactile hallucinations. He felt really strongly like someone was constantly pushing him from behind, like trying to make him fall over.
Wow, that sounds terrifying.
Yeah, and it wasn't just a weird feeling. It came packaged with delusions. He became genuinely angry and would physically search for the person he believed was pushing him.
So, okay, this case gives us a really clear, direct link then. A specific physical lesion from the stroke in that particular right side brain area seemed to directly trigger the tactile hallucinations, which he then interpreted, well, delusionally.
Precisely. And, this brain behavior link isn't even a new idea. Apparently, one source mentions the connection between cerebrovascular events and secondary psychosis was noted way back in 1879.
That long ago. Okay.
Yeah. So the key takeaway from this case for you, the listener, is how powerfully it shows that symptoms which might seem purely psychiatric on the surface
Right.
can sometimes have a clear, identifiable basis in physical changes in the brain. Understanding that connection is just absolutely crucial for diagnosis and treatment.
Okay, but then the question becomes, Are tactile hallucinations always a sign of something specific and physical, like a stroke? Are they always organic?
Yeah.
The sources you shared seem to challenge that idea.
They absolutely do. Yeah, there's a descriptive study in the material that took a really broad look. It examined all kinds of hallucinations across all sensory modalities, not just touch, in a population of patients with what we call primary psychotic disorders. So illnesses like schizophrenia, SC, schizoaffective disorder, SCA, and bipolar I disorder, BDI, with psychotic features.
Right. Illness is not primarily caused by another medical condition.
Exactly. And this study found something quite contrary to that older view, the one saying that TOGHs, that's the shorthand they use for tactile, olfactory, smell, and gustatory taste hallucinations,
TOGHs, got it.
that these TOGHs are rare in primary psychotic illness and usually signal organic disease. Well, this study found they were actually relatively common, reported by 20%, 1 in 5 of the total sample across these diagnoses.
20%. That's quite high, isn't it, compared to the expectation?
It really is. They showed up in all 3 diagnostic groups, though. The rates varied a bit. It was around 12% in bipolar disorder, 24% in schizophrenia, and nearly 30% in schizoaffective disorder.
Okay.
So this suggests that, in people with these primary psychotic illnesses, experiencing TOGHs is not necessarily some kind of red flag automatically pointing to underlying organic brain disease.
That changes the picture quite a bit. Now, let's look at another case report, because while this one is particularly striking, I think, it presents a scenario where tactile hallucinations were actually the very first symptom of schizophrenia. This is where it gets really interesting.
Okay, yeah, this one stood out. This case describes a 21-year-old woman, no previous history of mental illness at all.
Right.
And her initial symptom, the very first thing, was just feeling a light touch on her face while she was away at a camp.
Just a light touch.
Yeah.
And then...
Well, it escalated. Significantly, she started feeling touching on her legs and arms. She also reported seeing a dark silhouette, maybe a visual hallucination starting there.
Possibly.
Felt someone lying on top of her body. And then, critically, she began feeling sexually penetrated and assaulted daily by someone she couldn't see.
Oh, wow. That's incredibly distressing.
Extremely. These intense sexual tactile hallucinations became linked, the report says, to feelings of being dirty, like a whore, and being constantly raped by multiple men. Which sounds very much like the development of somatic delusions, right? These false fixed beliefs centered on one's own body or physical sensations.
Yeah, absolutely. The belief matching the feeling.
Right. And over several months, this whole picture evolved. She started hearing voices, developed clear paranoid and religious delusions.
Okay, more classic psychotic symptoms emerging.
Exactly. Which ultimately led to a diagnosis of schizophrenia. The report also noted, interestingly, a period of increased social isolation before the symptoms began, which is often part of the pre-morbid history in schizophrenia. This is the person's functioning and experiences before the illness really takes hold.
So the significance of this case for you, listening, is that documentation of tactile hallucinations being the absolute first symptom of schizophrenia is actually quite rare.
It is, yeah. You don't see it documented as the presenting symptom very often.
It really challenges that common idea, doesn't it?
Mm-hmm.
That schizophrenia always kicks off with auditory or visual hallucinations.
Mm-hmm.
And it highlights the incredibly varied and sometimes really unexpected ways that serious mental illness can first manifest.
Definitely broadens the perspective. Now, that descriptive study, it didn't just find that TOGHs are common in primary psychotic disorders. It also dug into what other symptoms they tend to show up with, what correlates with them.
Ah, okay. So looking for patterns, what did they find?
Well, interestingly, TOGHs were correlated with other types of hallucinations, so auditory and visual ones.
Okay.
Which, could suggest there might be some shared underlying brain processes, maybe something contributing to hallucinations across different senses in these illnesses.
Makes sense. A general vulnerability, perhaps?
Could be. What's also notable is their strong association with specific kinds of delusions.
Like what?
Somatic delusions, which we just touched on, those false beliefs about the body. Delusions of control, the belief that your thoughts or actions are being controlled by some external force. And thought broadcasting the belief that your private thoughts are being transmitted, like broadcast, so others can hear them.
Wow. So that cluster somatic control thought broadcasting, that seems significant.
It does. And the discussion in the paper suggests this clustering might point to a really fundamental breakdown in how a person perceives their own body and maybe where the boundary lies between their self and the external world. Kind of a blurring of lines.
That's a fascinating idea. There was another finding I found a bit surprising, though. An association with a lifetime history of a major depressive episode.
Yeah, that one stood out to me too. It's not immediately obvious why that link would be there, is it?
No, not intuitively.
This study also found something else interesting. Experiencing TOGHs was associated with an earlier age of onset for the psychotic illness itself.
Earlier. By how much?
The average onset was around 19.2 years for those with TOGHs, compared to 21.6 years for those without.
So a couple of years earlier on average.
Yeah. And an earlier onset is sometimes seen as an indicator of potentially a more severe illness vulnerability down the line.
Right. So putting this into context for you, the listener, understanding these correlations gives us a much more nuanced picture, doesn't it?
Definitely.
It's not just about ticking a box, has tactile hallucination. It's about how it fits into the person's overall symptom profile, what other experiences it travels with.
Exactly. And this kind of information could potentially help clinicians understand the severity better, or maybe point towards specific underlying mechanisms driving the illness in that individual.
Okay. Now, finally, let's shift gears slightly and look at a very practical point from another one of the case reports you shared. A potential low-tech way to manage persistent tactile hallucinations.
Yeah, this one was quite practical. This case involved a 23-year-old man with a really complex history. He had multi-sensory hallucinations, auditory, visual, and tactile. Particularly bothersome tactile sexual sensations.
Okay. And he also had a history of substance use and multiple hospitalizations, so likely quite treatment-resistant experiences.
Yes, it seems so. He reported feeling these phantom hands touching him sexually, around his chest, shoulders, or genitals, happening many times a day, really intrusive.
Yeah, incredibly so. And what was the critical observation in his case?
The key observation was this. The sensation, the phantom touch, would actually stop when he put his own hand on the area where he felt it.
Just by touching himself there.
Yeah, and then the hallucination would come back when he removed his hand. He also noticed that distractions, like just watching TV, offered some relief as well.
Huh. That's really interesting. So self-touch interrupted the hallucination.
Exactly. And this observation led the clinicians to explore tactile counterstimulation as a potential management strategy.
Counterstimulation.
Okay.
All right. What's the thinking behind why that might work?
Well, the proposed mechanisms are quite interesting. On one level, it might simply work as a form of distraction, right?
Yeah.
Redirecting the brain's attention from the internally generated hallucination towards real external physical input.
Okay, focus shift.
Or maybe more physiologically, it could be that applying real touch activates specific nerve fibers, the ones carrying normal touch signals, and these might actually inhibit the specific brain areas that are sort of misfiring and producing the hallucination, like overriding the faulty signal.
Got it. Competing sensory input, maybe?
Yeah. Something like that. So the potential value of this for you listening is that it's a simple, non-pharmacological approach described in this one case that seemed to show some promise.
Yeah.
Even for hallucinations that hadn't fully responded to medication, which is important. It suggests that for tactile hallucinations, simply trying to deliberately touch the affected area might be a worthwhile strategy to explore.
It really ties back to the brain's fundamental processing of sensation, doesn't it? How physical input can actively modify our perception, even perception gone awry.
Absolutely. So wrapping this up, what does this whole deep dive into these sources collectively tell us about tactile hallucinations?
Well, they're clearly far more complex, far more varied than a simplistic view might suggest, that's for sure.
Yeah. They occur not only in those maybe rarer organic brain conditions like stroke, but they're also found, and perhaps much more commonly than previously assumed, in primary psychotic disorders like schizophrenia and schizoaffective disorder.
And while it seems rare, they can even be the very first presenting symptom of an illness like schizophrenia, which dramatically alters that typical picture we might have of how the illness starts.
And their presence isn't just random noise either. It can correlate with specific types of delusions, like we discussed, a history of depression, and potentially even signal vulnerability towards an earlier onset or maybe a more complex illness presentation overall.
Right. And intriguingly, sometimes a physical intervention, something as simple as just touching the affected area, might offer a way to gain some control or relief from that phantom sensation.
Which is quite empowering, potentially.
It is. So thinking about all these diverse origins, these different presentations, and even these potential physical interventions, it really raises a fundamental and I think fascinating question for us to ponder.
What's that?
What do these very specific sensory misfirings like feeling a touch that just isn't there.
Mm.
What do they fundamentally tell us about how our brain constructs our subjective experience of reality? And maybe even our very sense of being a physical self within that reality.
That's a deep one to end on. Definitely food for thought.
Thanks for joining us for this deep dive.